Yeah, hi guys. Getting on to the part 2 section of our discussion of the AA gradient. Uh, like I said, it's a very useful clinical tool, and this part here is the application of your AA gradient. Like I said, most of the time the AA gradient will be useful in an acute setting or an emergency setting. We went through the equation to calculate the A gradient. We went through the calculation rule of thumb for the normal A gradient based on the age of the patient. We went through calculation of the FiO2, that is the alveolar oxygen component, based on the oxygen liters per minute, and that's the approximation, this part here. We went over the arterial blood gas component of getting the CO2 and the arterial component of the O2. We went over the approximation using our dissociation curve for approximating the PaO2 from the pulse oximetry. So using these tools we can calculate the A gradient, and that goes into the next step as to what needs to be done. There's one correction to the first video where I said the oxygen is freely diffusible. The important thing there is the PCO2 is 40 millimeters, usually because the CO2 is freely diffusible, very easily diffusible through the alveolar membrane, and that is because of God's infinite wisdom in ensuring that carbon dioxide goes out and oxygen comes in, and all the other metabolic processes continue. Therefore, carbon dioxide usually diffuses rapidly and freely, whereas oxygen takes a little more work to get through the alveolar arterial membrane. To get into the pathophysiology and the application of the A gradient, which you have calculated, and you have calculated in your mind using the tools described above, you have to have some prior knowledge about the anatomy of your capillary, or rather the alveolar capillary membrane, and the disorders that would be related to creating a VQ mismatch or to a pulmonary shunt, that is a shunt within the lungs or a shunt within the heart, and therefore differentiating these disorders based on the number and based on what you do. Okay, so now coming to this part of this section, the nurse has come to you. She has told you that patient oxygen on the pulse oximetry is low. You have said, let's get a blood gas. You have asked the supplemental oxygen to be given. Let's assume that you are delivering oxygen by nasal cannula, and patient is feeling a little bit better. He's talking to you, or maybe he's not talking to you, depending on either or all of this follow. This is the flowchart that you go through in your mind to figure out where do I place this particular patient with hypoxia. Starting off, what you have done is you have asked for a gas, and on the gas what you're looking at is the partial pressure of the CO2 or the PaCO2 on the ABG, and you find that the PaCO2 has increased. The only mechanism by which the PaCO2 can increase if it is not blown off or if it is not ventilated, which means that there is hypoventilation. Now, hypoventilation can mean that somebody is holding his breath and he doesn't want to breathe. It could be a child who is throwing a tantrum and he decides, I'm not going to breathe, I'm going to hold my breath, and you do whatever you want. You can administer one on the side of the head or something like that and get it to breathe again, and so that it starts blowing off the PaCO2, rather the CO2 and the PaCO2 would start dropping. On the other hand, it could be a patient who is unable to breathe due to fatigue or due to narcotic ingestion, or patient's status of motor vehicle accident and his respiratory drive is subdued. It could be a variety of other mechanisms, and therefore the ventilation is not happening, so he's hypoventilating, and therefore the PaCO2 is high. That goes into the CO2 aspect of your blood gas, but we are interested in the A gradient. So now going to the right side of this particular flow chart here, if the PaCO2 is not increased, and or it is normal, let's say, and you find that the A gradient is increased after you have done this particular calculation based on your oxygen liters per minute, pulse oximetry approximation, inspired FiO2 from here, and the PaO2 from the blood gas or from this particular approximation. I'm saying that again and again. The reason I'm saying it again and again because it's very useful to keep it in mind and use it as a handy and a quick tool before all the tools are given to you, all the readings are given to you, all the blood gas comes to you. You can just make a rough estimate and see where the A gradient stands. So you figure that the A gradient is increased. We also assume that you know the age of the patient. You have looked at his history sheet and you have looked at his age. His sex will be evident, but you have looked at the age and you made your calculation based on that particular equation. So age is important in this particular game. So you figured out that the A gradient is increased, and you, like I said, when you talk to the nurse, you said give some oxygen to the patient, so the patient is getting oxygen. Now, if the PaO2 is corrected after increasing the oxygen, rather, is the PaO2 getting corrected after you have increased the flow of oxygen, the delivery of oxygen, or the concentration of oxygen? Is it increasing? How do you know that? By looking at the pulse oximetry. You gave the supplementary oxygen, the pulse oximetry improved. It went from, say it was 80, it went to 98%. That means that the PaO2 is also getting corrected when you are delivering the increasing oxygen. Why? Based on this. As the pulse oximetry is improving, saturation is improving, it means that the arterial O2 is also increasing. Say the pulse oxygen is 96%, it means that the arterial O2 must be more than 85 to 90 millimeters of mercury. Therefore, the PaO2 is increasing. So it is getting corrected with increasing oxygen. So if it is getting corrected by increasing the oxygen, it means that the increasing AA gradient was coming because of ventilation, perfusion, mismatch. What does that mean pathophysiologically? Pathophysiologically, it means that there is a mismatch between the flowing oxygen, that is the ventilation, and the flowing blood, that is the perfusion. Okay? Now, when does VQ mismatch happen? There are some examples here, and these are common clinical examples. These are the common clinical examples which you will encounter in your life in Ward 20, when you will start from here and you will work your way back. Okay? Or you will, once you reach here, then you will work your way back again and figure out if your hypothesis was correct or not. Alright? And VQ mismatch will happen in asthma, where the problem is bronchospasm. So when there is bronchospasm, there is a problem with the ventilation part of it. So the ventilation is not good, perfusion is there is VQ mismatch. You give oxygen, the A gradient gets corrected. So this ventilation problem. Interstitial lung disease. Interstitial lung disease is affecting your membrane, that is the alveolar and capillary membrane. So if you have interstitial lung disease affecting that, you will have perfusion problems, because interstitial lung disease will cause destruction of your alveolar capillaries. So there will be ventilation happening, but not good enough perfusion. So there is perfusion mismatch. Therefore, there will be improvement in the PaO2 if you give more and more oxygen, so that it goes and saturates whatever blood is available in the alveolar-capillary membrane. Interstitial lung disease also can have a ventilation mismatch because of loss of elasticity of the lungs. So patient has difficulty inspiring and expiring efficiently. Okay, so that's loss of elasticity is the mechanism of the pathophysiology for the ventilation mismatch in interstitial lung disease. And last clinical example will be pulmonary embolism or pulmonary vascular problems, wherein there is a perfusion mismatch. There is nothing wrong with the ventilation, there is nothing wrong with the air going in and out of the alveoli, but there is a problem with the blood supply going through the ventilated part of the lung. So the Q is not correct. So there is VQ mismatch again. Again, you give increasing amounts of oxygen or increasing concentration of oxygen, and whatever oxygen, increased oxygen concentrations are flowing through the lung will saturate whatever blood is available away from that part which is not having the embolus. Okay, there are other mechanisms that enter into the picture, but usually in this particular clinical situations, that asthma, interstitial lung disease, pulmonary embolism, you will find that there is correction of the arterial oxygen and the hemoglobin saturation when you give increasing concentrations of oxygen. Okay, now suppose you find that the pulse ox doesn't improve after you have increased the flow of oxygen or the concentration of oxygen. What is the mechanism there? The mechanism is a shunt mechanism, meaning the blood that is supposed to be oxygenated does not come into contact with your increasing oxygen concentration. That means that the blood is being bypassed before it gets oxygenated. That means that the blood does not reach the alveolo-capillary membrane for the exchange of carbon dioxide and oxygen to happen. When that happens, non-oxygenated blood and carbon dioxide rich blood will continue to flow through the system because oxygen is not being exchanged for carbon dioxide. And the only mechanism that can do that is a shunt. The shunt can happen in multiple places. It can happen in the heart. It can happen in the lung. It can happen at the alveolo-capillary membrane itself. Okay? So in the heart, the clinical example would be, suppose you have a ventricular septal defect with Eisenmenger syndrome or something like that. So if you have Eisenmenger syndrome, then there is direct transference from the right side of the heart to the left side of the heart. It doesn't reach the lungs. It goes directly into the aorta and it flows through the body. Okay? So that is the intracardiac shunt. If it goes directly from right side of the heart to the left side of the heart and flows through the body, it has never reached the lungs, it has never reached the alveolo-capillary membrane, you have a shunt. Therefore, you can give as much oxygen as you want. It will not get oxygenated. And the A gradient will not get corrected. It will remain increased. Okay? In the lungs, you can have a pulmonary AV fistula. Suppose you have a pulmonary AV fistula. What is an AV fistula? It means that there is direct connection at the pulmonary level between the arterial side of the circulation and the venous side of the circulation. What will happen? Blood will flow from the arterial side, it will go through the fistula into the venous side and recycle. Alright? So it will never get to the capillary membrane part of it to get oxygenated. And you can give pump as much oxygen as you want through the alveolar tree. Because the blood is being shunted through the AV fistula, it will not be oxygenated, the A gradient will remain increased. Okay? There are many other examples where the A gradient is increased due to shunt mechanism. It happens in pneumonia, it happens in alveolar collapse or atelectasis. And atelectasis can happen due to a variety of reasons. Suppose you have a mucus plug in your airway, your lungs will collapse. If you have pneumonia and you have fluid-filled lungs, your lungs will collapse. And what the body does, it is readjusts the blood flow. It takes the blood flow away from the collapsed part to the part that is being ventilated. This is just normal mechanism. So the body does the shunt. And God in His infinite wisdom tries to put blood into the area where there is oxygen. But there is not enough oxygen for the amount of blood that is being shunted, as in ARDS, pneumonia, extensive pulmonary atelectasis or alveolar collapse. That is when there is fluid-filled lungs or a mucus plug that is blocked your bronchial tree. At that time there is intrapulmonary shunt again, and again oxygen is not being delivered, but it does not reach the capillary membrane, and therefore there is no oxygenation. And even if you increase oxygen supply, the A gradient does not get corrected. Alright? So common things here that you will experience would be something like asthma, something with interstitial lung disease or interstitial lung disease. Pulmonary embolism also happens fairly frequently. Pneumonia, ARDS in an ICU setting, cardiac shunt in a coronary unit or in a intensive cardiac care unit, and intrapulmonary fistula even again in ICU setting. So some of these conditions you will experience in the ICU setting, Some of these conditions you will experience in the non-ICU setting or even in your regular outpatient department. You have to look at the patient, you have to make the calculation, you have to see how ill he looks, you have to look at the change in his oxygenation status based on your intervention after you increase the oxygen supply, and you have to remember this flow tree to make a clinical assessment of not just the patient's condition but of his oxygenation status. Okay, we are not discussing therapeutics here, but we are discussing use of the A gradient. So A gradient is a very useful tool to deal with all these common clinical situations that show up, and also as to what you want to do by intervention. Intervention is actually very simple. Most of the time you say give oxygen, not working, give more oxygen, not working, give even more oxygen, still not working, intubate the patient and deliver oxygen artificially, ventilate the patient artificially. That's all well and good, but the fact still remains that you have to have a sense of what is the pathophysiology or what is the pathologic physiology that is causing this particular phenomena to happen. One additional point that I would like to make here is you can correlate the A gradient with your radiologic picture, with your X-ray or CT scan picture. Okay, so now if just one example here, but we don't have time to go through all the examples, maybe we will do that in another session. But if you look at the X-ray of the chest and you find that patient has consolidation, has an opacity on one side, okay, he has opacity on one side, and you gave him oxygen and you thought this is pneumonia because that's very common, and you gave him oxygen and his oxygenation improved. What does that tell you? Well, there will be other clinical signs, you know, with this so-called non-pneumonic process, because if the oxygenation improved after you gave him oxygen, it means that maybe he doesn't have pneumonia, maybe he has something else. Maybe he didn't have fever, maybe he didn't have a white count, and maybe the consolidation in the lungs was purely a ground glass opacity, as you would see in interstitial lung disease. Therefore, you have an additional correlation between the calculated A gradient which you have calculated in your mind and the visualized radiologic picture. Suppose you have a CAT scan that shows profound atelectasis. If it shows profound atelectasis and you have an A gradient that's increased, it is in the ICU setting, you can come to the conclusion that this is either florid pneumonia or acute respiratory distress syndrome, and you have validated your CT or X-ray picture based on the A gradient and the radiologic picture. So you have to have a correlation between what is happening on a two-dimensional radiologic picture, between what is happening with these numbers that are showing in the blood and on your measurements, pulse oximetry, and correlate them with the underlying pathophysiology. Alright, thanks very much for listening.